heart of innovation. 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by patient advocacy group thewaytomyheart.org in partnership with Cardiovascular System Incorporated's patient advocacy campaign, Take a Stand Against Amputation. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of The Way to My Heart, Kim McNicholas, and interventional cardiologist and founder of the Save My Piggies Health Education Series, Dr. John Phillips.
Hey everyone, and welcome to the show. I'm in Denver, Colorado today. Really exciting. I have a lot to share about my experience here with the world-renowned Dr. Ehrin Armstrong, so stay tuned for that. But we're going to be talking about carotid artery disease. You know, a diagnosis of a narrowing in or blocked arteries leading to your brain can be really, really scary. Just ask Nancy from South Carolina. She was diagnosed with carotid artery disease and learned that because of it, she was at risk of stroke. The carotid arteries, one on the right, the other on the left, are major blood vessels in the neck that supply blood to the face, the neck, and your brain. 1/3 of all strokes are related to diseased carotids. Carotid artery disease occurs when fatty deposits or plaque builds up in these arteries. And what's scary is someone with this disease often does not experience any symptoms in its early stages. It first becomes obvious when it's serious enough to deprive the brain of oxygen, leading to stroke or a transient ischemic attack or TIA. Nancy was one of the lucky ones who discovered it early because she was being monitored closely following a heart attack. And she's going to be here to share her journey from diagnosis clear to treatment, which just happened last month. And that's going to pave the way for a grander discussion on carotid artery disease, current diagnosis and treatment guidelines, and ongoing discussions amongst industry and government leaders that will impact how and when physicians can provide more than medication to improve that blood flow and prevent life-threatening complications. So a big show ahead. But you know what? It's already been a big morning for you, John. So you're all set to go, revved up and ready.
Yeah, I have the pleasure of being on call again this weekend.
Everyone else on summer vacation.
Well, yeah, you got to let your partners take time off and whatnot. So I've got several calls in July, but I treated a patient with a pulmonary embolism. So she a young person and had COVID about 3 or 4 weeks ago and was, we don't hear much about COVID anymore. It's as if it never happened, but nonetheless, she had COVID a few weeks ago, was laid up pretty sick. And because of that was not moving around much. And that is a risk factor for developing a blood clot in the leg veins. And, a certain percentage of those folks have some of that clot jettison its way and get stuck in the pulmonary arteries and can cause a pulmonary embolism. And she was very short of breath. And our intensive care physicians kind of picked up on this. And obviously we had a CAT scan. That's the way we diagnosed this. And she had a lot of clot. And we felt like she would benefit from removal of some of that clot. So we took her to the catheterization lab and basically sucked the clot out with a long tube and a syringe, and got her feeling better right away. And hopefully she'll be able to go home tomorrow. She'll need to be on some blood thinners for a while, but we felt like we helped somebody today, and that's always a good feeling.
Oh, what a way to kick off the weekend! Not only saving legs, but also now saving a life.
Well, yeah, what the intro that you provided is very fascinating to me. I know Ehrin does carotid work. I don't do carotid work anymore. I had to choose between carotids and superficial venous insufficiency in treating veins. So I decided I was going to do veins and let my partners do carotids. But talking about carotids is it's a difficult subject for patients. We know that, and I'm just looking at the NIH website here, about 800,000 people in the U.S. have a stroke a year, and about 140,000 of them die. And a lot of those are what we call ischemic in nature, from lack of blood flow, not necessarily. And then, the other percentage are when a blood vessel breaks. But there are a lot of people that have blockages in their carotid arteries that because like we've talked about, right? You can get blockages in the leg arteries, the heart arteries, the neck arteries. The blockage doesn't really care. And there's still the same risk factors: high blood pressure, cholesterol, diabetes. But, Ehrin's an interventional cardiologist, as am I. And when someone has a blocked artery in their heart, they often have symptoms, and we open up that blocked artery and they feel better. But folks with carotid disease don't necessarily, a lot of them don't have symptoms. And so then we're kind of hemming and hawing about how we should treat it. And we're going to get into that.
Treat or not to treat, right?
Well, yeah, exactly. And then the other issue too is explaining that to the patient, because in their mind, they're like, well, wait a second, I've got a 70% blockage here, and you're not going to do anything other than put me on cholesterol medicine and watch my blood pressure. And, so it's an interesting topic. We haven't talked about carotids yet after doing 50 plus shows. So I'm excited to hear Nancy's story and kind of get into it.
Yeah. And it was interesting because being in Denver, Colorado, I had the opportunity. I'd been chasing after Dr. Armstrong for a couple years now. I heard he was in Colorado. I heard he was the go-to guy. And, people traveling in from everywhere to come in and see him and have him save their legs and their life. And so I had some patients that I was working with, and I'm trying to ask everyone and anyone, how can I get in touch with this guy? I need to get these patients to Dr. Armstrong. No one seemed to know where he was until suddenly I was visiting a lab down in San Jose, southern San Francisco Bay Area in California. And one of the sales reps for a company called Cardiovascular Systems Incorporated, or CSI, they create that little sanding device, the orbital atherectomy, the one to unblock arteries. And
they also sponsor this show.
And they also sponsor this show. So it's a really good point. But I just happened to be down there in the cath lab talking to this sales rep and watching procedures down there. And she said, you really should go meet this Ehrin Armstrong over in Napa. And I said, the Ehrin Armstrong? And so I was able to then get to meet him there, get him a couple of patients. And then just when I'm getting used to him there, he's back to Colorado. And I'm telling him, now you need to get that former football star Deion Sanders to you and have you save his legs. So, Ehrin, we're talking about you, but we might as well say hello to you as well.
Oh, thanks very much, Kim. And sorry to have been so elusive in the past, but glad to be back in Colorado as well. And thanks for having me on the show here. I think it's really great. I'm really looking forward to hearing Nancy's story and answering any questions about carotid disease. Because I think, John, as you mentioned, it is one of these things where the majority of the time people are not having symptoms. But, I think knowing that you have a severe blockage in the neck arteries and the risk of stroke associated with it, I think, the reality is nobody wants to have a stroke. And we'd like to do everything possible to try to prevent it as well.
Yeah. Well and said. You did a couple carotid cases this week, which I didn't. I was so sad. I was like, I wish I knew. I wanted to go watch them, observe them. But I did get to spend a couple hours in his cath lab. Only a couple years old. It's absolutely beautiful. Where he saved the leg of a man who had a toe wound, and he was able to open up the arteries. And then I also had the opportunity to watch a venogram, where he was checking out the veins in a very young patient. And he was able to get her back on her feet as well. So that was really fun to see you in action.
Yeah, it was great to have you there, Kim. And we do a lot of work in the hospital, and, the carotid artery cases Kim mentioned did in a hospital setting, because patients do have to stay overnight after doing those types of procedures. But we also have our own freestanding surgical center where, thankfully we can do a number of these leg procedures and patients go home the same day. So it really gives kind of the opportunity for patients to be treated in different settings, depending on kind of what's easiest for them from an access standpoint and the ease of treating patients. So it's great to have you.
Yeah. And I hope to be back again. Well, coming up right here on The Heart of Innovation, we're going to get into the heart of our topic of the day, which is carotids. And before we do, we're going to have that moment of inspiration from Dr. John Phillips. So stay with us. You don't want to miss that either.
leg health can indicate risk for heart attack, stroke, and amputation. If you have leg pain or cramps while walking, get checked for peripheral artery disease, or PAD. PAD is plaque buildup in mainly the leg arteries. Be sure to ask your physician for an ankle brachial index, also called an ABI test, where they use blood pressure cuffs to analyze the blood pressure in your legs. If they discover you have arterial plaque that's limiting blood flow to your feet, medicine and a regimented walking program are frontline treatment. If PAD is in its advanced stages, your physician may schedule a surgical intervention. Minimally invasive tools are available to remove plaque and restore blood flow, including Cardiovascular System's Diamondback 360 atherectomy system, which sands away plaque that is a hard calcium. It's important to discuss all options with your physician, and if told you have no options, get a second opinion. Take a stand against amputation. For more information, go to standagainsamputation.com. That's standagainsamputation.com.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Dr. John Phillips' spectacular vascular moment of inspiration.
One was, out of your vulnerabilities will come your strength. So, and then dovetailing into that, and again, this was, in the 30s or 40s. And so he uses a man instead of person, but he says a man should not strive to eliminate his complexes, but to get into accord with them. They are legitimately what directs his conduct in the world. And I think last week's show was about a patient who kind of overcame obviously that acute heart attack and the coronary artery disease. And now we have Nancy coming on who kind of overcame some the carotid disease. So I like the quotes about, kind of facing your demons and slaying them. And it allows you to have some balance in the world. So thanks to Sigmund Freud for those two quotes.
Yeah, and I think, Nancy, I saw you nodding your head. It rings true to you. You felt like a ticking time bomb for years, right?
Yes. Well, I've had a lot of things wrong. I've been fighting this over 20 years. Diabetes, coronary artery disease. I also, with the coronary artery disease, I had a lot of angina and pain and misdiagnoses on a couple of stress tests, and I had a widowmaker, and but I had an EMT next to me who saved my life. That was 8 years ago, and so I've been fighting it all. And then 4 years ago was diagnosed with PAD, with peripheral artery disease, and then a year and a half ago diagnosed with the carotid artery disease. So I'm fighting it all. I'm 70 years old, and about a year and a half ago, like I said, I was diagnosed by an endocrinologist PA. She heard a swishing sound in my neck and was referred. She sent me for an ultrasound. I have carotid artery, was sent to MUSC in Charleston, had a vascular surgeon there. She watched it for a year and a half and was at 70%, and then it inched up to 80%. And she just kept saying, it's too risky, it's too risky. And when it started getting up over 80% a little, I contacted Dr. Anazana, and he said, I want to get a CT scan. And at that point, it was 90%. So I had the TCAR surgery done June 10th. And it's successful. I am asymptomatic. And Medicare has just come in and approved people who don't have any symptoms. Prior to this, they didn't even approve TCAR surgery. So I was very fortunate. I was really blessed with all of this. And I keep coming through. They say I'm like a cat with 9 lives, but I'm fighting hard. So
Ehrin, if you could share with us, so when you see a patient with vascular disease, you're examining them, right? And let's say you hear the swishing or a bruit. What are you thinking of? What's your treatment or testing algorithm? How do you work that up?
Yeah, that's a great question, John. I think, the first thing, and I think that's great, Nancy, that the endocrinology PA actually heard of bruit in the first place, because I think the reality is too often physicians or advanced practice providers are not listening to the neck arteries to try to hear bruits. It's not a perfect test. There are cases where you can have carotid disease and not have a bruit. But, if your physician or practice provider hears an abnormal sound in the neck area, that should set off some concerns that there could potentially be a carotid artery lesion. And the best screening test in those cases is a carotid duplex, which is an ultrasound test. It only takes about 20 minutes or so to do, but it can be very effective in identifying, whether there is a carotid artery stenosis and in general about how severe that lesion is. Ultrasound is not nearly as specific as a CAT scan because the CAT scan can give you a very definite number, but it can give you a good range and help determine what the next step should be in therapy for carotid artery disease.
Could I ask
Nancy,
a question?
Yes, please.
Why do we have to wait so long? I felt like a walking time bomb for a year and a half, and it got to 80%. Every time I saw the vascular surgeon, she said, it's too risky. It's too risky. Where Dr. Antizana referred me to a neurosurgeon to do this. And I'm so glad it's over with. What a relief. And I'm okay. And I got through it. I was so afraid of having a stroke during the procedure.
Right. There is something to be said about the fear that you feel when you're told that the arteries up to your brain are starting to clog up, and to be sent away with just some medication and told, well, we're just going to take a wait and see approach. It's too risky to touch. You do go home with a lot of fear.
Well, I'll answer it, and then I'll let Ehrin share his thoughts. But there's risks to having a procedure done, whether it's a stent or a clean out surgically. And so I think the physician, and we know the risk of having an event without cleaning out the artery, meaning medical therapy, is probably higher when the vessel gets narrowed to, that 70 to 80% range. And so we have to weigh the risks and benefits of the procedure because, again, like I'd mentioned in the intro, patients who have coronary artery disease have symptoms, and we put a stent in, their symptoms get better. A lot of these folks don't have symptoms. They don't know they get a stent or whatever. They don't feel any different. You're just trying to reduce their stroke risk. And so you don't want the patient to have a stroke on the table having a procedure. And again, that's at least the philosophy that we use in our practice.
Yeah, historically, the risk of causing a stroke when treating a carotid artery lesion, whether it's by surgery or with a stent, has been around 4%. And so we're looking for that point where a blockage is severe enough that the risk of having a stroke in the next year is more than 4%, so that we're not, doing a procedure and actually increasing the risk of stroke. Now, I think a few things have changed about that recently. One is that with newer TCAR procedures and newer types of stents, and in the hands of experienced operators, the risk of a stroke is probably 1% to 2% with procedures. The other thing, though, that's complicated is that with more modern therapies like statins and some other cholesterol medications, the risk of stroke per year probably has gone down compared to when it was studied initially, like 20 or 30 years ago.
We'll come up right here on The Heart of Innovation. We'll have more about carotid artery disease and some of the discussions about future treatments of it. So stay with us.
3 years ago, my symptoms started with leg pain and leg cramps while walking.
Me too, with a tightness in my calves.
Well, do you know, my doctor thought that my leg cramps were a side effect of the statin he prescribed me.
Well, my doctor just brushed them off as another symptom of old age.
Mine thought the pain was radiating from my spine.
My doctor blamed my neuropathy on diabetes until I got a wound on my foot that just wouldn't heal.
Yeah, it turns out we all have peripheral artery disease, also known as PAD.
It's plaque buildup mainly in the leg arteries causing poor circulation.
For me, the diagnosis came too late and I lost my leg, but that does not have to happen to you.
No, it does not, because there are treatment options available if you're diagnosed early enough.
PAD. peripheral artery disease. If you've been experiencing leg pain, leg cramps, or neuropathy when walking, and your doctor isn't hearing you, we are. We are the Way to My Heart, the largest support network for peripheral artery disease patients, and we want to help you get back on your feet again. Visit our website at thewaytomyheart.org or call our Leg Saver hotline 415-320-7138. Your life and limb could depend on it.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. We're continuing our discussion about blockages in the neck arteries called carotid artery disease. And kind of before we went to break, Ehrin, you were just touching on some of the treatment options. And so let's go back to that question I asked about you evaluated a patient, you heard a bruit or that a noise in the neck, you got the most, the cheapest and a nice kind of test from a sensitivity specificity standpoint, the ultrasound. Let's say the patient comes back and we get these in ranges and they have what we call, a moderate blockage, 50 to 69%. What are you thinking and what are your next moves with respect to starting medications for them, if any?
Yeah. So for patients who have, a carotid lesion that's under 70%, so in that 50 to 69% range, that's really where I think what's most important is to make sure we can address any risk factors for carotid disease worsening and medical therapy for it. So the mainstays of therapy, they have a lot of overlap with treatment of heart disease or peripheral arterial disease. So they include a baby aspirin every day, a statin if you're able to take it, or if not, some of the newer cholesterol treatment drugs to get the LDL as low as possible. And then, obviously smoking cessation is a big one. And then some newer data also suggests that some other blood thinners like rivaroxaban may have some additional benefits in patients with carotid disease. Patients with carotid disease were included as part of a big study called the COMPASS trial that showed a reduction both in stroke, but also the other things that can happen like a heart attack, in patients with carotid disease. So those are the mainstays of medical therapy.
And then let's say it's between that 70 or greater than 70%. Do you then get more testing to kind of better define the blockage, or are you still sticking with assuming they have no symptoms? Because we're talking about people that don't have symptoms. Obviously, if someone has a blockage and they're having symptoms, meaning mini strokes or have had a stroke, that puts them in a different category that needs to be addressed. They need to be treated. But these are asymptomatic patients. So now you've got a 70 to 80% stenosis. Are you thinking about anything different now, or are you still continuing with aggressive medical therapy?
Yeah. So, definitely continue with the medical therapy, but generally if somebody has a blockage that looks like it's getting above that 70% range based on an ultrasound, then what I usually do is get a CAT scan of the neck and the head. And that's helpful for a few reasons. It tells you anatomically what's going on, but it also gives a more exact number for the percentage of the blockage and some other things like how much calcium is there in the blockage, where is it exactly? And also importantly, the head CT part of things could show maybe there's a history of a small mini stroke that didn't cause symptoms or something else. And if that's the case, that might actually change kind of the decision making about when to treat the blockage as well.
And Marcy is calling in. Marcy has a question. Marcy, what is your question?
Okay. Years ago, my right was 60%, no one did nothing about it, and then it ended up being 100% the right side. So now the left side's 40%. And I have a lot of problems on the left side, like my face. My arms also, they said, was clogged, left arm. And then I had that aneurysm with my angel Ken there. Found me somebody, because I had an AAA, no one was doing nothing about it. And my legs were clogged, and I had, I guess, grafts put in. And they then I was able to walk again because I could hardly walk from one room to the other because of the hip pain. And I had injections, epidurals, and none of it was working.
Wow. So she's just been brushed off so much. And, you know, with that 100% blockage in her carotid and the history of it moving really fast, progressively just getting worse and worse quick. Now she has the other one. What should she be expecting of her doctor? What should she be asking?
And the neurologist also said to just like, I forgot her name, Nancy. Is that her name?
Yes.
Okay, yes. He was saying the same thing. It was too risky.
So at what point, why are there so many different type, philosophies on treating? Why do some treat? Why do some not treat? What are your thoughts?
Well, so the beauty of the system, meaning blood flow to the brain, there's kind of 4 highways, and I like to describe it as a roundabout up top. And so you've got two arteries in the front, two in the back. The ones in the back, the vertebrals are a little bit smaller, but it affords you, Mother Nature, God, or whoever you believe in is pretty smart in the design. And so you can have a blockage of 100% in one of them and then some mild blockage in the other one and still be fine, right? But Ehrin, it's an interesting question because a lot of people come to you and say, hey, this artery is blocked 100%. Why don't you open that up for me? But we're really not doing that, are we?
No, we don't. Unlike in leg arteries or even heart arteries where we'll open up 100% blockage, in general, if something happens and a carotid artery blockage has gone to 100%, unless it just happened a few hours ago where there's clot that could be sucked out, we don't treat those 100% blockages. And the main reason for that is that, as you said, there's other collateral pathways. And then also trying to open up that blockage, the risk of causing clots to break off and go up into the brain farther outweighs, I think, any benefits in those cases. So that's why we're trying to catch these blockages before they get 100%. But, once they get completely occluded, then the question becomes monitoring all those other blockages, like on the left side, for example.
Now, do you wait? If she has a 40% blockage in her other carotid artery, do you wait then until it's over 70% in order to treat it? Or do you start and try and do something now?
I think in that case, do some close surveillance. So probably an ultrasound every 6 months to keep an eye on things. And then I would probably have a lower threshold for getting the left side treated. So once it did get around that 70% range, then I'd go ahead and treat it. And another important thing is if you already have a blockage on the other side, getting surgery is riskier on it. And so it would be preferred to do some kind of a stent procedure, whether it's a TCAR, as was mentioned, or a carotid stent, because you don't have to deal with the blood flow being blocked for a period of time as you do with surgery.
And we have a question coming in right now from Douglas. Douglas, what is your question for Dr. Armstrong?
Yes, sir. So in the very beginning, what are some of the signs that you're having these issues? Do you have to have a stroke for this to be diagnosed or ask your doctor about, or are there certain signs?
Yes. So that's one of the tricky things with carotid disease is a lot of the times you don't have symptoms until you have a stroke. So what I would say, is that your doctor should listen to your neck to hear if there's a bruit. And if you have a history of heart disease or have peripheral artery disease, I think it may be reasonable to consider getting a duplex of the carotid arteries, just because the chance of having a carotid artery blockage is a lot higher if you've got blockage in other arteries. The other warning sign of carotid disease is a medical term called amaurosis fugax, which is a fancy way of saying a shade coming down over your eye. So if something happens where your vision is fine and then suddenly you go halfway blind in one eye or even completely blind in one eye, that can be an early warning sign that a stroke is potentially about to happen. And that occurs because a little piece of clot will break off from the carotid artery and go to the eye artery. So that's one of the warning signs where if something like that happens, you should call your doctor or go to the ER emergently and get that evaluated, because it could be
right there. On the Heart of Innovation, we're going to give you a key question to ask your doctor to see if you are at risk of carotid artery disease and a potential stroke. So you don't want to miss that. Stay with us.
Hi, I'm Simon Greenwood, a clinical vascular scientist originally from the UK, currently working in Calgary, Canada, with this week's medical notepad. And today we're going to talk about what you can expect when your doctor orders a vascular ultrasound. A patient would typically arrive at the reception area, have a seat in the waiting room, and get called through for their ultrasound exam. And when they enter the room, they'll be greeted by the sonographer performing the test. There's a separate changing cubicle in each room for the patient. Depending on what test is being performed, you may be asked to change into a pair of shorts. Once the patient is changed into the appropriate attire, the patient will then be asked to lie down on the ultrasound bed, and the technologist performing the scan will explain the procedure, where they're going to be looking, what they're going to be looking at, and what happens with the patient's results following the exam. And for a leg arterial ultrasound scan, we start at the groin for each patient, and then we basically follow the leg down to the ankle. We're going to be applying some jelly, and we're going to be taking pictures at multiple levels, basically to ensure that we're imaging all of the blood vessels as we need to, and making the most appropriate diagnosis. The majority of our tests are actually performed on the legs, and it's for patients who've got pain when they're walking, numbness, tingling, cold sensation in their legs, or non-healing wounds. So we perform an ultrasound scan looking directly at the blood vessels in real time to assess for any narrowings or any blockages. And our vascular interventional radiologists will do a really detailed written report. With this week's medical notepad, I'm Simon Greenwood.
Medical Notepad is a series for educational and informational purposes only. Advice offered is not a substitute for medical advice from your own supervising physician. Do not act on any information provided in this series without the explicit consent from your own healthcare team. For more information on peripheral artery disease, go to standagainsamputation.com, and for peripheral artery disease support, go to thewaytomyheart.org.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Just before the break, we were touching on some of the symptoms of carotid disease, mini strokes, things of that nature, the curtain going over the eyes. But during the break, Nancy, you were sharing with us that after your procedure, you felt kind of a little bit sharper, had less fatigue. Can you just share with us some of the change that you felt?
I think the biggest change was my mind just felt clearer. It just cleared up. Like I was in a fog at times, and I just felt I felt so much better, just better, more alert, subtle. It was subtle, but I feel so much better.
Ehrin, is this a placebo effect, or is this real in your opinion?
I don't know.
I think it is actually real. We don't see this all the time, but especially in patients who already had an 80 to 90% blockage by the time they're treated. I would say about a third of the time, patients come back and they tell me they feel sharper. They think they can think more clearly. I've also seen people who are sometimes very dizzy, which we don't usually think of as a symptom of carotid disease, where that gets better as well. So I think it's an understudied area, but there are, these other symptoms that we don't recognize otherwise that are related to severe carotid disease.
Yeah. And you and I are both interventionalists, so we make our holes with needles and tubes. We're not surgeons. So a lot of people listening might think, well, maybe if I have a blockage, I should have a stent. But what are your thoughts on having surgery for it?
Well, I think, all the therapies that are available for carotid disease are effective. Surgery, of course, was developed first, and it was studied back in the 80s or 90s, 30 or 40 years ago. And that's what forms the basis for treating a blockage that's over 70%. There were actually studies where they looked at medical therapy versus surgery in those cases, and surgery was shown to be better. And then subsequently, as stents were developed, there's been studies comparing stents to surgery, showing that they're equally effective. I think that it's a individual decision, but it also can depend on some other factors like what the blockage looks like, how much calcium there is there, and also where it's located. If the blockage is very high, then surgery becomes a lot riskier, and it's better to do a stent versus where the blockage is in the neck artery itself. So there are a lot of complex aspects. I think the most important thing, though, is just the decision to do a revascularization, whether it's by surgery or by a stent.
And it's nice knowing that there are a variety of options now, but there's still something to be said that if you do like a doctor or you're in an area that doesn't have all of these advanced options, that it's really good to go with what does that doctor do all the time and where are they successful? What do they do well?
Well, I think I'm going to let Ehrin take this, but I think that is a huge point because in our institution, which is why I got away from doing carotids, because we just didn't do enough of them. And so we said, all right, we're going to have a couple of physicians do a lot of these. And yes, like with anything, you want to have a physician who's done the 10,000 hours, right? The 10,000 hour rule. So the more procedures that a physician does, whether it's carotid or anything, the better he or she is going to be. And you want to find whoever does it, whether it's a surgeon, interventionalist, you want to make sure that they're doing a lot of these, right, Ehrin?
That's absolutely true. I think that's true of any kind of procedure or surgery, but I think it's even more true with carotids because, the risk of causing a stroke is something that no one wants to do. And there have been studies showing that doctors who are higher volume at doing either carotid surgery or carotid stenting have better outcomes. So I think Kim's point about, whatever it is your doctor does the most of and is best at, then that's the way to go.
It's interesting, too, because there's an article in the Wall Street Journal today that looked at age of hospitalists and their mortality rates. And they found that the younger hospitalists, so 40 to, I think it was under 40, or then they broke them 40 to 49 and whatever. But the younger ones had a lower mortality rate than the older hospitalists. But conversely, surgeons and interventionalists, the older surgeons, the older interventionalists who had more experience had lower mortality rates. So again, you just want to find somebody who does a lot of these.
I think that's key.
Of anybody in San Antonio that specializes in that? I've had so many.
We'll get to you offline with that one.
Yeah, that's a really good question. We do need to find someone that does it. It's really important to meet with multiple doctors before you decide on who might be best for you and the option you're most comfortable with and does fit your situation best. But Ehrin, there are a lot of discussions going on right now about the future treatment. And there is this push and pull between a couple of different practices, interventional cardiologists and vascular surgeons vying for for these procedures, what's right, what's not right. Can you bring us up to date on these ongoing discussions? And especially, I believe they involve Medicare and reimbursement as well.
Yeah. So, all of these procedures, whether it's carotid endarterectomy, the TCAR procedure, which involves a small incision in the neck and placing a stent in the carotid artery, or carotid stenting, which is usually done through, the groin, similar to doing a heart stent. Any three of those procedures are approved by the FDA, but the reimbursement for doing them is actually different. And it's complex, and there's a number of political reasons for it and whatnot. But carotid stenting historically has not been reimbursed by Medicare if it's for an asymptomatic patient. Medicare will only pay for symptomatic carotid stenting. And there's some exceptions to that, and there's ways to do it in the setting of a trial. But right now, there's a reconsideration going on with Medicare with regards to paying for carotid stenting. And things are looking pretty hopeful and optimistic, actually, that there'll be a change in the coverage decision, which I think ultimately benefits everyone because it helps allow more opportunities for treating patients with whatever doctors think is the best way of treating their carotid disease.
That was a wonderfully politically correct answer, yes. Dr. Armstrong. you did not step on that landmine that Kim threw in front of you.
That's right.
On that note, we'll be right back with final thoughts from Dr. Ehrin Armstrong and Dr. Phillips on carotid artery disease, as well as that critical question to ask your doctor to see if you are at risk. So stay with us.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
So, Kim, we only have a few minutes left. You have to tell me, what is this crucial question that every patient needs to ask their physician?
Hey, doctor, what do you think? Let's chat. And chat is an acronym for C, carotids, H is for heart, check the arteries, check for valvular issues, check for AFib. A is for abdomen, check for an aneurysm, an abdominal aneurysm. And T is for toes. Check those leg pulses, those foot pulses, those toe pulses to see if you're at risk for peripheral artery disease as well. So chat every single, especially if you have those high risk factors, high blood pressure, high cholesterol, diabetes, former smoker, obesity, any of those factors, or if you have any sort of symptoms, make sure you do ask your doctor every year, every appointment. Please, doctor, let's chat. And Dr. Armstrong, especially with the carotids, it's as simple as just taking their stethoscope and putting it up to the neck.
Yeah, absolutely. I think that just listening at the neck is a good initial screening test. And if you do have any of those other problems, including blockage in the leg arteries, it's reasonable to discuss whether to do an ultrasound of the neck, regardless of whether there's a bruit there or not.
Now,
and I'm curious.
So I was just going to say, Nancy, you had a pretty astute nurse practitioner listening to your neck. So kudos to whoever did that. Because I don't know about you, Ehrin, but I've got a finite amount of time to see patients. And sometimes, that stethoscope, for me, it gets pulled out every time. But I've had some colleagues that say, I don't even carry a stethoscope anymore. So always remind your doctor and be your own best advocate for sure.
And I'm just curious, Dr. Phillips and Dr. Armstrong, when someone comes in and they're complaining about leg symptoms and you treat the leg symptoms, they come in for the follow-up, how often or what are the incentives do you have to actually go in and say, well, since you have peripheral artery disease in your legs, artery issues there, let's check your neck, let's check your heart. How often does that happen?
Well, I mean, I think for those of us that are vascular specialists, we should be doing a head-to-toe vascular exam. It doesn't take but a few minutes. And we know that a certain percentage of these people have overlap or polyvascular disease. We've talked about it on the show. Ideally, you have them on the appropriate medical therapy, which includes an antiplatelet, aspirin or Plavix or something, a statin or something for their cholesterol. You've talked to them about risk factor reduction. You talked to them about smoking cessation. But yeah, as Ehrin said, I mean, if you hear bruit, get an ultrasound, or patients who have first degree relatives who have had AAAs. So talking about family history, aneurysms, and get them screened. So there's a lot of tools out there that are cheap and very effective to kind of screen patients, put them in the right bucket and get them the appropriate care.
And I'm curious, Dr. Armstrong, so many people are going to go get checked and their doctors may tell them they have a 40, 50, 60% blockage. How can you ease their fears if their doctor says, yes, you do have this severe narrowing in your neck arteries, we're not going to treat you. How do you alleviate that fear that they are that ticking time bomb?
Well, the good news is that even if you have some carotid artery blockage, that blockage, if it's in the range of 50% or even 60%, as long as you're taking an aspirin and getting your cholesterol treated, the risk of having a stroke every year is still very low. It's probably only 1 or 2%. It's really after the blockage is over 70 to 80% that number starts to creep up and go above 5%. So I know it's scary to think about having like a 40 or 50% blockage, but the reality is that the risk of that progressing to a stroke is actually still pretty low.
Fantastic. Well, thank you so much, Dr. Armstrong, for joining us, for Dr. Phillips and all of our amazing audience. Thank you so much for joining us. And I hope you all
real quick, you're in Denver. What are you going to do?
We're going to the Rockies, headed to the Rockies. And I have Amish cousins. So we come from the Amish and they came in from Pennsylvania by train and then by automobile. And we're going to meet them up there in the Rockies and hit the trails.
Fantastic. Hope is the weather good?
The weather, it's been a little stormy, but it's supposed to get up into the 80s and 90s and clear in the next couple of days.
Awesome. Enjoy.
Thank you. Bye, everyone. Have a great weekend.
Thank you.
Bye, everyone.
You've been listening to The Heart of Innovation with Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips. Our mission is to help patients live a better quality of life through comprehensive education, real-time support, and high-touch advocacy in partnership with thewaytomyheart.org and Take a Stand Against Amputation. Our purpose is to reduce the 1.5 million heart attacks and strokes and nearly 200,000 amputations annually. For more information regarding topics you've heard discussed on today's program, go to theheartofinnovation.org. That's theheartofinnovation.org. The Heart of Innovation is for educational and informational purposes only, and advice and views shared are not a substitute for medical advice from your own supervising physician. Do not act on any information provided in this show without the explicit consent from your own healthcare team. If you think you are having a medical emergency, call your local emergency number or go to the nearest hospital or emergency room.